Yellow, let's live together, happily and faithful. Yellow, twikale pamo, nesansa no kwichindika.
Life is a dream altogether that makes it so easy to keep on living, working so hard in the dream of tomorrow, knowing nothing, having nothing, only having it.
We live in a world with AIDS, and for the people of Zambia, the dream of tomorrow is overshadowed by the reality they face today of living with the devastation and hardship caused by the dual epidemic of HIV/AIDS and TB. 1 in 5 adults in Zambia is infected with HIV, the virus that causes AIDS, and the number of new TB cases is over 40,000 each year. A major problem for Zambia is how, with limited economic resources, to provide basic care and support to those affected by the dual epidemic of HIV and TB. In the late 1980s, a strategy known as home care was developed to provide basic medical and nursing care to individuals affected by the HIV/AIDS epidemic. However, relying totally on healthcare professionals to visit people in their homes proved to be time-consuming and relatively expensive. In Zambia's Copperbelt province, the health department of the Ndola Catholic Diocese saw the growing problem and found its solution in the wisdom of a traditional proverb. Only those under the Mupundu tree hear the fruit fall. This Bemba proverb simply means that those closest to the problem understand best how to deal with it. This is how the health department of the Ndola Catholic Diocese responded to their problem of home care. Recruit and train volunteers from within the community. People who understand the problems caused by HIV/AIDS and TB because they live with them every day.
The community volunteers speak the same language. They live the same lives. They have the same pain. And I'm not saying that for every program you need those elements, but I think in this case it helps. Volunteers who can counsel, they know what situation people live in. Now if you bring in professionals who live in a much better off area, they have a different kind of pain. They have a different life. Also, volunteers are there 24 hours a day, 7 days a week. So when there is a problem, you know where she lives, where he lives.
The Ndola Catholic Diocese covers the Copperbelt province of Zambia, which takes its name from one of the world's richest deposits of copper ore. The Copperbelt is the most urbanized of Zambia's provinces, with 80% of the population living in 7 towns, which grew up around copper mines. On the outskirts of these towns are shanty townships with populations of 10,000 to 40,000 people. It is in these townships that the church first saw the growing numbers of people who needed to be cared for. they began a home care program in 1991, working in 2 townships. The program now covers 23 townships and has over 5,500 chronically ill patients on its register. Volunteers for the program are recruited mainly through the churches in each township. Although administered by the Catholic Church, the program actively promotes the involvement of volunteers from all churches. However, church membership is not a requirement for volunteers or patients in the program. Most of the funding for the program is provided by a European donor consortium. The operation of the program varies in each township, but the basic organization is the same. Volunteers are given an initial 2-week training course in basic health care, with ongoing training courses given periodically. From a base within the township, the community nurses working for the home care program hold meetings with the volunteers, keep patient records, and conduct clinics for patients in the program. Patients who are too ill to walk to the clinic are visited in their home by the nurses. Each township is divided into sections. Volunteers visit patients in their section and report to the nurses each week. Rosemary Ngulube is one of the 22 volunteers in Ipusukilo Township, situated on the edge of Kitwe, the largest city in the Copperbelt. Rosemary, a mother of 6, became a volunteer in 1993 when the project started in Ipusukilo.
When we go to visit patients, we ask them about their health. We encourage them to take their medicine. If they are too ill to rise, we help them take their medicine, cook for them, bathe them, change their bedding, and encourage them. That is why we go to visit them. We also spend time with the relatives of the patients. We encourage them to see that their sick family members take their medicines all the time, and we teach them hygiene and how to prepare oral rehydration salts. Being a volunteer is not easy, but one of its rewards is that I have learnt a lot of things. I did not know that you could actually nurse a patient at home here in the township. I now know that you can nurse a person at home, and you can take that person to the hospital. I did not know the importance of hygiene, but now I do. But more importantly, I did not know how to write or how to read, but now I know how to read and write.
The office for the home care program in Ipusukilo is at the government clinic. So as not to congest the clinic, the community nurses conduct the home care clinic in the yard outside a volunteer's house. Each morning, they move to a different section in the township. This allows the nurses to see about 150 patients each week and helps them to determine who needs to see the doctor. Monday is a special day in Ipusukilo. Every Monday, Rosemary and 2 other volunteers accompany patients from the township to a home care consultation clinic at Kitwe Central Hospital. Doctors examine and treat the patients referred by the nurses from the 12 townships with home care programs in Kitwe. Rosemary and the other volunteers accompany the patients as they are seen by the doctor to provide background on the patient's medical histories. Patients' records are kept at the Clinical Pastoral Care Center, which is on the grounds of the hospital and is also supported by the Ndola Catholic Diocese. After the clinic, the volunteers meet with the Pastoral Care Center staff to review each patient's progress. Through this arrangement, the home care program and the hospital reinforce one another. The program relieves some of the burden on the hospital, and in return, the hospital avails its facilities and personnel to the program. This is one example of the many developments that have occurred since the program started.
When we started the program, the assistance was aimed at the sick individual. And what we tried to give them were necessary drugs, something to eat if they had a bit of comfort. Now we've seen over the years that that's not sufficient. So we've changed that scope. We now aim at the family An individual who is sick is part of a family, so the support is aimed at the family as a unit. And we've learned that there's more needed than a couple of drugs and a bit of food and so on. So what we provide or try to provide these days is medical care, so to treat the common conditions seen in AIDS patients. We provide nursing care through some people are bedridden or floor-ridden in some cases. They have sores, they have difficulties in sitting up and to drink, so that needs nursing care. And the welfare aspect is a very important aspect. A lot of people have lost a job because of their illness, and the social security doesn't exist, at least not a formal system, so people have no income. So you have to provide food if necessary for the patients. Another very important aspect is the, you can call it psychological, the spiritual, pastoral help, and that can be having a prayer together by washing the vegetables. I would call it also psychological help. Having a good talk, sit down with somebody, not necessarily talking about all the problems they have, but maybe talk about just day-to-day activities, what happens in the surrounding. And the last but not least is the counseling and the testing. So all these elements, the medical care, nursing care, psychological, spiritual support, the welfare, testing, counseling, we try to provide an holistic package for the patient and his or her family.
Pastoral or spiritual care is at the heart of the volunteers' work. In all their activities, their main concern is to be there for the patients, praying with them, listening to them, and helping them to find spiritual strength through their faith. Nkwazi is one of 4 townships on the outskirts of Ndola where the Diocesan Health Department supports a home care program. One of the first townships in the program, Nkwazi, has 52 volunteers caring for over 400 patients. The base of operations is the Chishilano Support Center on the edge of the township. The center also accommodates several income-generating projects for chronically ill people. Regina Banda has been a volunteer in the home care program since 1991. Regina sets off early to visit some of our patients because of the unique nature of the visits. Several of our patients are on TB treatment, and she monitors them using the DOTS strategy. DOTS, or Directly Observed Treatment short course, is a strategy whereby the volunteers visit TB patients every day and watch them take their medication. In most cases, this ensures completion of the 8-month treatment course without the patient needing to be hospitalized.
DOTS means making sure that someone has taken their medicine. For example, you give it to her and she takes it, then you give her the water and she drinks it. Then you mark your chart. That is DOTS.
Each township home care program that incorporates the TB component is registered as an official TB control center. Volunteers are trained to collect sputum samples which are taken to the hospital for tests. If the test results are positive, the patient is counseled and prescribed the treatment course. Patients are entered in the TB register and the volunteer keeps a chart of the patient's progress. The drugs are distributed to the townships by the district health authorities. Nkwazi Township became a TB control center in 1995. Since then, they have registered a 69% completion rate, compared to 20% in most low-income areas where DOTS is not practiced. This is significant because the number of new TB cases reported each year in Zambia is 4 times what it would have been without the HIV epidemic. So, the incorporation of DOTS in the home care program is an important strategy in fighting the dual epidemic of HIV and TB. And as Regina and our patient can testify, even people living with HIV can recover from TB by following the DOTS strategy.
Dots actually works. I have seen that Dots works. I had a patient, a woman, who was very sick. When she came out of the hospital, she was very sick and had to be carried everywhere and given a bath. But when she finished her Dots, she picked up. She walks, she's put on weight, and all the slimness is gone. She is fat now.
I
was tested and told I had the HIV virus. Then I felt seriously ill again, and they took me to the hospital, tested me, and told me I had TB. They started me on treatment, and I finished it. Up to now, I know that I'm cured. When Regina came to visit me, she would sweep the house, go to the clinic to collect my medicine, bathe me, and give me the medicine. After I took the medicine, she would then go away. She used to encourage me not to worry too much, not to despair, that if you follow the instructions and take the medicine we are giving you, you will get better. And I did.
Regina enjoys being a volunteer, especially now that her husband is more supportive.
When I started volunteering, my husband was very doubtful. But when he became sick, he saw how I cared for him and how much I was able to help him. Then he realized that my work was not useless. It has a purpose. So, now he encourages me. When I tell him that I am going to visit, he doesn't stop me. I even leave him to care for the baby.
Dominic Nkazi is a 44-year-old father of 8 and a long-time resident of Nkwazi Township. Despite having a full-time job as a road technician for Program for Urban Self-Help, Dominic still finds time to work as a home care volunteer.
I'm interested in helping some other people. There's no much reason why I'm taking time off go for this home-based care. It's only that I don't know whether it's a gift from God that I should do, assist some other people in other ways, which I don't know. On Sundays, normally we choose those who are very, very sick. That's the patients we go around visiting, so that we have the full report to the sisters on Monday. We go as in a group, maybe we're 3 or 4 visiting the patients. When we go to visit our patients, we normally ask how that patient is feeling, then asking him or her whether he's taking some medicines. We ask for the envelopes where they put in medicines. If we go, we check the medicines. If he or she is taking, we count the medicines according to the days indicated on the envelope of which he or she has to take the medicines. And educating their relatives as well to care for them, because we have some patients, some of them, they don't even wake up, you see. So we clean their beddings, their surrounding. Sometimes those who are unmarried, we sometimes wash their clothes and they cook for them if there's anything to be cooked for them.
On the outskirts of the small town of Muflira lies Kawama East, the home of Sandra, who has been a volunteer in the home care program since 1996. Following the wisdom of the proverb, Sandra has something extra to offer her patients, since she completely shares in their suffering.
It's good, it seems okay.
I realized that it would be good for me to volunteer because I am also HIV positive. I wanted to be able to encourage my friends that although they are ill, they should not neglect themselves. Because some do neglect themselves, saying, I can die any time. Since I am HIV positive and a volunteer, I try to explain to them and ease their worries. No, look here, it's like this. And I try to show them the importance of accepting their lives and trying to live with HIV. Live a positive life. When I go to see my patients, I examine the place where he or she is staying, how it looks, and the people they're staying with, whether they look like they're cared for or not. I also discuss with the relatives and make sure they know how to look after the patient.
Sandra's willingness to serve as an example for others also has some benefits for her.
I have benefited by having acquired nursing skills. Now, even when my own child at home is ill, I know that the reason she's having this disease is because of this or that. I also know what kind of medicine the nurses can give her, or the medicine I can give her.
In Kawama East, the home care program operates out of this mud-walled shelter built by the local residents. Once a week, the community nurses hold a clinic here and also receive some special visitors. The Ndola Catholic Diocese noticed a serious increase in property grabbing from widows, a practice whereby the relatives of the deceased husband remove what they consider his property from the widow's house, often leaving her destitute. In response to this, a workshop was held on widows' rights and gender issues. Attending the workshop were members of the Victim Support Unit at the Mufulira Police Station. Understanding that these cases are police issues, officers from the Victim Support Unit now travel to Kawama East each week to check on any cases of property grabbing or child abuse. This is a good example of how the program collaborates with other sectors of society. Back in Ipusukilo, Rosemary is visiting a special patient, Josephine. Josephine has recovered from TB using the DOTS strategy. When Rosemary first visited Josephine 6 months ago, she couldn't walk, talk, eat, or even see properly.
That time, I was very sick. I wasn't able to walk. Even when I stood, I failed to walk. I couldn't even see properly. Rosemary had to carry me from my house to the car. She'd lift me, put me in the car, and take me to hospital. But when I came home from hospital, I had no power. My legs became numb. I couldn't hear. So it was Rosemary and my grandmother who used to go, collect my medicine, and bring it to me. Rosemary used to come every day to encourage grandmother to hold me, give me the medicine and the juice to drink. 2 weeks after starting the medicine, I felt a bit better. I even started eating. At present, I'm feeling very well. I don't feel any pain. I'm even slightly fatter. That time, I was just bones. If Rosemary hadn't helped me, I would have been dead.
When a patient has been sick for a long time and then gets better, I feel my heart rejoicing, and the happiness between us continues. We laugh and sometimes share about how ill she had been. Sometimes they tell me, if it weren't for you, I wouldn't have gotten better. So I feel very happy because we talk about her life or the lives of other people and hope that they will also get better.
Many are the tragedies caused by the HIV/AIDS epidemic. Perhaps one of the greatest is the increasing number of orphans. According to UNAIDS, Zambia has one of the highest proportion of orphaned children in the world. An estimated 23% of children under 15 have lost one or both parents, and the numbers are expected to rise. This is painfully obvious to the volunteers, who, when caring for patients, can easily identify soon-to-be orphans. They use this early detection system to try and secure a stable future for the children while there's still time. The home care program supports several thousand orphans by paying for food, housing, clothing, and schooling. In some townships, this assistance is channeled through a local NGO, Children in Distress, or Cindy. In Ipusukilo, however, the assistance is more direct.
Since we started
the home care program, the number of orphans has also increased. And it has been our responsibility to look after these children as well, because it's not just fair. You nurse the parent, the father, you nurse the mother, they die, and then you say bye-bye to the children. You find that you can't just do that. So we've ended up now starting an orphan care programs. When the parents die, we make sure we find somebody to stay with these children if there's nobody to stay with them. And we help them with school. We organize school fees, we make sure they've got food, and we make sure somebody is there to look after them.
With all its various components, the home care program provides invaluable services to the people of Zambia's Copperbelt. It is also a tremendous asset to the Ministry of Health Sector Reform Program. Dr. Moses Sichone is a Public Health and Clinical Systems Manager for the Central Board of Health based in Zambia's capital city, Lusaka.
I think the concept of home-based care is an extremely important innovation in our response to the HIV/AIDS epidemic in Zambia. You will remember that in the early days of the epidemic, we began to see more and more patients occupying hospital beds in our institutions, in our health facilities. And that meant that the quality of care for the patients who were in the hospital began to suffer because health workers were overloaded with patients who were very ill. And so home-based care in this country has become a very important strategy for dealing with HIV/AIDS. And I am quite satisfied that the home-based care programs that are now in operation in many parts of the country are doing very well in providing quality care to patients that are desperately need this type of care. One of the most important developments in Zambia has been the advent of the health sector reform program. As you know, since 1991, we have been engaged in the process of reforming our health sector so that it can provide equity of access to cost-effective quality health care as close to the family as possible. So there has to be this continuum of care between the formal healthcare system and those that are providing care in the community through the home-based care. And I think it's an excellent opportunity for us to ensure that quality care is provided at all the different levels of the healthcare system.
And what makes the home care program a success is the cooperation between the various partners.
The success of programs like this one depends on a number of inputs. I think one of the most important ones is the community, with their community volunteers who provide all their labor for free. And without that, these home care programs wouldn't exist. But you also will need material and financial input for the volunteers to do the work together with the nurses. You need money to buy the drugs, for the food, for the transport. And of course, another important input you need is collaboration with existing structures. It's obvious that you need a good collaboration with the formal healthcare structure, and the local clinic, the hospitals. Well, actually, as it is a multidisciplinary problem, you need actually contacts with a whole variety of departments and institutions. But I would say the three main ones: the community themselves, for the volunteers, the donors for the money, but also for the know-how and the support, and the formal healthcare system. Those three are very, very important.
In the end, it is the volunteers themselves who will ensure the sustainability of the home care program. As they continue living under the Mupundu tree, in and among the people and their problems, they continue to give, offering themselves as best as they know how.
our program has been successful, I think because the community is fully involved. It's a community program, and these women have really been recognized by the community, and they are respected for what they are doing. They are like consultants, you know. They are consulted even for small things, and that's nice. It's good to be, we all want to be recognized and accepted.
As a Christian, I believe that God gives me blessings in other ways because of the work I do as a volunteer. Most of my friends think I'm mad to be working the whole day, running to the hospital without getting paid. I tell them that's my gift from God, to be looking after the sick.
Well, anyway, my friends, when we started, they were laughing at me that how can you work voluntarily without getting anything from what you are doing? You are doing a tremendous job, but you are given nothing. I said, well, anyway, you don't know. Sometimes now, as I'm talking now, there are some who are willing now to come and join me.
The reason I do this work is I just give myself up to work for people, to visit in the township, to see patients. I just give my heart to do this work.
Leva pela fiancé, loku bachiti la fiancé, bantu te bolse mayo, abaite benoit. Nawalwala etse kwe bati chakwila po, nawalwala etse kwe bati chakwila po, tiwai kale miake ingi no kubombe chito yonse. Tuikale miake ingi no kubombe chito yonse. Tuikale pamoja tumfwane. Lesunga winwa balwele baeti. Lesunga winwa balwele baeti. Tuleva bela fiancé, loku bachiti la fiancé. Tuleva bela fiancé, loku bachiti la fiancé. Bantu te bolse mayo, abaite benoit. Ngawalwala etse kwe bati chapuila po. Ngawalwala etse kwe bati chapuila po. Tuikale miake ingi no kubombe chito yonse. Tuikale miake ingi no kubombe chito yonse. Tuikale pamoja tumfwane.